Alex?
Yes, thank you for the presentation. And I came in only about 2/3 of the way through. So a question about, two questions actually. One about this notion that suppose we start from zero, there's no intervention. And then the rich start benefiting more from a given intervention than the poor. Now, it's true that that increases inequality between the average of the rich and the poor. But if the people getting the intervention in their lifetime health would be much worse off than even the healthy among the poor, outcome inequality in terms of how many healthy life years do you get by the time you meet your maker may decrease even as uptake is inequitable across income groups. So I think it's quite important from an equality point of view, where we care about outcome inequality as well, that this isn't the only metric one considers, because what you're regarding as a worsening may in fact, even from an egalitarian point of view, not merely a total well-being point of view, be an improvement. So.
No, point well taken. I agree, and that will go into the next version of the presentation. I think in Bangladesh, I remember it no longer be true, a survey of about 10 years ago saying that study from ICDDRB showing that I think measles vaccination saves 6 times as many lives in the poorest 10% of the population as in the top 10%. And if you have that situation for a particular intervention, then your outcome is going to be very different from the income. I would also add
Sorry, that's not quite what I meant. Even, look, take a rotavirus immunization, right? Suppose only 10% of the poor get it and 50% of the rich.
Right.
Now, among those 10% of the poor who get it, some who would have died would be among the worst off in terms of income and health. But now they're no longer because they live much longer, right? Meanwhile, some among the rich who die young because of this disease are, in fact, considering everything among the worst off. So all I'm saying is increased coverage among the rich or higher coverage among the rich than among the poor doesn't imply an increase in inequality in what we should really care about, which is lifetime utility or well-being.
No, that is a different point. I agree with that one, too. And let me just, while I'm at it, throw in a comment that Dean Jameson made during discussion. Shouldn't we also be looking at the absolute position among the poor on intervention coverage, not just the relative? And my memory is, I really hadn't thought of that. I agree with it, and I think in most of these cases, even when inequalities are worsening, the poor are getting at least somewhat better.
Yeah, this is just really a question of clarification. So I wanted to go back to your IPM measure. So my understanding is that the coefficient is positive when when you have this convexity. And then concavity means that that's moving you closer to equality, and that takes on a negative coefficient. And this, maybe I'm not understanding this so clearly, but it seems to me like what we should also care about, in addition to, or maybe even more so, is the slope of the line, rather than the.
Yeah, this is not a measure of the slope of the line. It's a measure only of the pattern. So therefore, it's only partial.
I would be a little harder than that. I think that it's more than partial. It's quite incomplete because what it seems to be capturing is how people in the middle of the distribution are deviating from where they would be if things happen in a stepwise fashion, and that it seems like what we really care about is how large the differences are between those at the bottom and those at the top, and that's really captured by the slope of the line.
By the slope. Yeah. Well, fair enough. That's an interesting point.
And then just a very quick second comment, which is that if you see that the pattern is changing over time in longitudinal data, rather than throwing out the middle observations, there may be something very informative about the process by which a distribution becomes more or less unequal over time. Here in the United States, there's just this sort of pattern that I've observed with racial and ethnic healthcare disparities, where sometimes it's like darkest before dawn, which is to say that when there's a new technology or a new intervention available, the most advantaged tend to get it most quickly, and then right when the disparity is largest, then
things go poof.
Yeah.
Yeah. Yeah. Well, if that's true, that's encouraging. One other thing I should have added is, which isn't really, fair enough, I'm just not prepared to rest in comfortable that the poof might happen. It might or might not, and I don't know quite how you could tell from the data.
Well, it's something that you can suss out using the full time series rather than throwing out the middle observations.
Yeah. Well, let's discuss that. The other thing I should have mentioned is I'm beginning to think we should pay less attention to the averages and look at the outliers and see if we can tell what the outliers are doing differently from each other.
Across countries.
Across countries. Yeah.
I was wondering, the programs that you put up, and you said really it looks like a mess if one looks between the cross-section and the longitudinal, what it is that it's telling us. Would we get more information through some more qualitative sense of where each of these programs and how actually they're going about being rolled out? Because that might then show us a pattern of which ones end up really increasing the inequality. Because in as much as I'm very much on the side of saying that universal health coverage just like that doesn't, is likely to give you inequity. In fairness, on the other side, that's obviously not what people are looking at. I mean, they're hoping that by making it universal, they'll get all kinds of things coming into the program, et cetera, all the stuff that we know. So does it require more sort of fine-grained qualitative work to be able to answer?
No, I would think so. I think that's the route to go, is what are the factors among programs that determine whether or not they are equitable or not. And you have the very difficult problem of sorting out site-specific characters, too, because an approach can be equitable in one, will not necessarily work the same pattern in a different setting. But yes, I think that's right. We've gone about as far as we can go with this.
I mean, just to follow up a little bit on that, I mean, one can think, for example, about a BedNet program, which is announced to be universal, but in its actual rollout, it's done in a manner where, they actually start with those at the bottom and move up differently, or, whatever. I mean,
I'm not too worried about BedNets, at least, because they're going so fast. The problem was oral rehydration went very fast, too, at the start, and had stalled and remained stalled, I think, at 60%, something like that. Okay, well, please. One brief question?
Yeah, sure. Thanks, Dave. Very interesting. I know that we've, at WHO, have tried to consider, on one hand, the visualizations, particularly in policy discussions, and in a report we did for the African Regional Office that you're very familiar with. One of the things that we realize is that the policymakers want to see the average as well, and they want to understand the inequity. They're most interested in the average, but if you can give them both. So we tried different ways to visualize both the change, and numbers like concentration indices were difficult to communicate.
That's right.
So the visualization using either some examples of these different lines, but at least in our test, we found that they all understood very well still the ratio of the worst to the best, quintile, which of course doesn't give you the middle, but if you give the concentration index as well, And we plotted over time from at least two DHS surveys for different indicators across all the countries, like 30 countries. We did a very simple graph of putting what was the change over the ratio on one axis and what was the change in the national average on the other axes. And then you got 4 quadrants. And there was a quadrant that you'd want to be in where everything's going right. And you had a quadrant which we put in red where you didn't want to be in, and then the orthogonal. And as you mentioned about the sort of the cases, you try to look at those positive things and see, you know, relatively why is this the case. So it was a nice way to visualize both the average and the inequity.
Right. That was a good report.
So I want to thank Dave Gwotkin. You have been one of the persons really pushing equity onto the agenda for many, many years. So I think it's very fortunate that we have you here and that we can continue this work. So I think we should now start the official program, and I'd like to thank you all for waiting due to factors beyond our control. It's very unfortunate, and we hope that some more people will be able to arrive here, but I think we should start. And as I said before, that we try to go a little bit quicker through our presentations and also shorten the discussion time so that we can get through most of the program. We were sitting at the Friendly Inn and really wanting to get over here because yesterday was such an interesting day, and we were looking forward to today's presentations. So I will hand over the chair to Sharmila Matre from IDRC, Canada. Yes. We hope we will be able to extend the program further on into the evening, yes.